Hello and welcome to BunMed, where we discuss concise medical knowledge that you can fit inside of a bun. In this video, we're going to be having a look at disseminated intravascular coagulation, or DIC, why it's such a massive medical emergency, and what we can do acutely to treat it. Okay, so what's DIC? Well, DIC refers to disseminated intravascular coagulation. And from these, we can understand that we have formation of lots and lots of clots inside of our blood vessels all over our body by the use of the word disseminated. Okay, so how does this process occur and what actually goes wrong? Well, this process will get started off with something, and we don't exactly understand what that exact thing is. And it could be many things, but some of the more common things that we are aware that it can be caused by is things like snake venom, sepsis, pregnancy, malignancy, specifically if you have a type of acute myeloid leukemia, where you have a 15-17 translocation, or pre-myelocytic leukemia, you're at a really high risk of this, and as well as that, trauma, okay? And a good acronym to remember this is snake spit poisons many times. So snake for snake venom, spit for sepsis, poison for pregnancy, many for malignancy, and times for trauma. And we know that this process actually goes on to activate our clotting cascade inappropriately by activating factor 7A. So factor 7 and factor 3A is activated in an inappropriate manner, and therefore this kickstarts the clotting cascade. So what actually is it? Well, we have uncontrolled formation of clots all over our body due to the inappropriate activation of the clotting cascade. And every time we form a clot, we actually use up those clotting factors. So therefore, we end up using up not only the clotting factors in our body, but also the platelets. So as you can imagine, as this process gets kick-started, we start to form these clots. Now these clots, like we saw in many other times before, are actually quite sharp. So as blood cells try to pass through them, they get sheared in half, leading to hemolysis. So this is another type of microangiopathic hemolytic anemia. Now these clots can then get deposited all over the body, leading to symptoms of things like thromboses, both in the venous and arterial system. But the more important thing is that we actually used up the clotting factors. So therefore, we're at a significantly higher risk of bleeding. In fact, any tiny trauma can cause us to bleed. So therefore, this condition is a true medical emergency. Okay, so what sort of symptoms are we going to see? Well, we're going to see symptoms of the underlying condition. So for instance, if it's like sepsis, you're going to see symptoms of sepsis like a high fever, tachycardia, potentially things like shortness of breath, drowsiness. But in terms of the condition itself, you're going to see things like oozing from venipuncture sites because we can't clot. And this may occur completely spontaneously. So for instance, where you put in a cannula or a venipuncture, the site just randomly starts bleeding. You might also notice spontaneous bleeding from other sites, such as the mouth or the ears. Other things include, from a more clotting side of things, that if these little clots get shot off, they can actually get lodged in smaller vessels, like those in your hands and feet, leading to digital infarcts. A digital infarct refers to the death of a finger or toe. And it's pale because it can block off one of those arterioles. So this is a very serious condition. So what sort of investigations are we going to want to do? Well, the investigations that we're going to want to do is to start off with some basic bloods. And the first thing we do is a full blood count. Now, because this is a microangiopathic hemolytic anemia, we're going to see a thrombocytopenia and a normocytic anemia. The next thing that we're going to want to do is a blood film. The reason we do a blood film is to detect these things known as schistocytes. And schistocytes is, again, like I've said before, where a red cell is cleaved in half, leaving these helmet-shaped remnants of the red blood cell. The next thing we want to do is some U's&E's. Now, U's&E's are really, really important, as any sort of systemic disease like this tends to affect the kidneys the earliest and can lead to acute kidney injury. So therefore, we may see things like a raised urea and raised creatinine. On the side, you should also do something like a urine dipstick, which may show the presence of blood or protein in your urine. The next thing we want to do is clotting studies. Now, this is where it starts to get interesting, okay? Because you can't actually localize this lesion. Okay, what has actually happened? Well, we have started to form uncontrolled clots using the clotting cascade. So all of our clotting factors have been used up. But in the using up of those clotting factors, we've used up our platelets as well. So we have a deficiency now in both primary and secondary hemostasis. So you're going to see a raised bleeding time as well as a raised PT and raised APTT. Now our body is very interesting in the fact that it will not deal with so many clots in our body, and it will actually try to break down these clots. And in the process of trying to break down these clots, it produces a type of protein that we can detect by doing some D-dimers. And in DIC, because we're forming so many of these clots, our D-dimers is significantly raised. Another thing that we can do is do a serum fibrinogen. Now remember, we are again forming lots of clots all over our body. So therefore our serum fibrinogen tends to be low because we are using it all up to form all these clots. And therefore this is what leaves us at such a high risk of bleeding. So what's our management? Well, in any acute condition like this, the first thing we do is an ABCDE. And we also try to treat the underlying cause. So if this is sepsis, start them on the sepsis 6. In order to actually deal with the underlying clotting disorder in terms of a bleeding disorder, we actually try to replace all of our clotting factors by giving them fresh frozen plasma. And this essentially contains every single one of our clotting factors, and therefore it's very effective in the treatment of disseminated intravascular coagulation because it replaces all of the factors in one go. The next thing we can do is give cryoprecipitate if fibrinogen is low, because cryoprecipitate is a concentrate of things such as fibrinogen, factor VIII, and von Willebrand's factor mainly. So you can see it does replace quite a lot of the factors that we're deficient in. And we also want to give supportive care. So what I mean by this is if they need fluids, give them fluids. If they need oxygen, give them oxygen. And this is basically based on the patient needs. And last thing, of course, as I said before, the biggest thing to stop it going on is to treat the underlying cause. That concludes the video. Hope you guys found it useful. Please feel free to share and subscribe. And if you have any comments, leave them below and we'll get back to you as soon as possible. See you in the next one.